Okay. Good morning, everyone, and thank you for joining us. We are excited to see so many of you on the webinar this morning or this afternoon, depending on where you are. Our webinar today is Suicide Prevention and Substance Use with Justice-Involved Clients, and our presenter today is Dr. Jennifer Johnson. The hosts today are the Great Lakes ATTC, the Central East ATTC, the Great Lakes MHTTC, the Central East MHTTC, and SAMHSA. We are funded by SAMHSA. We are the ATTC, MHTTC, and PTTC, all at the University of Wisconsin in Madison. These are the grants that we are funded on. Because we are funded by a federal agency, the information provided today is from the presenter and does not necessarily reflect the opinions of the SAMHSA or the director. And some housekeeping details is this webinar will be recorded and available for viewing along with the PowerPoint slides and transcripts on our YouTube channel and the Great Lakes PTTC website. There are no CEUs or certificates of attendance offered for this webinar. Today's audio is broadcast through your computer speakers, so please make sure they are turned on and up. There is no call-in number available. We'll use the chat box feature throughout the webinar to ask questions or add comments. A Q&A session will be held after the presentation. Our presenter today is Dr. Jennifer Johnson. Dr. Johnson's studies include the first large randomized trial of any treatment for major depressive disorder in an incarcerated population, the first randomized trial of suicide prevention for justice-involved individuals, and an extensive study of the scale-up of postpartum depression prevention program in 90 prenatal clinics serving low-income women nationally. She has also researched interventions for HIV prevention, suicide or sexual assault and partner violence prevention, and prenatal bipolar disorder. Her overall goals are to improve the well-being, increase agency, and reduce preventable suffering of women and girls, justice-involved individuals, and Flint area citizens. Her policy goals include reducing incarceration rates and preventing gender-based violence. We are very excited to have you this morning, Dr. Johnson, and I'm going to turn it over to you.
Fantastic. Welcome. I'm excited to see so many mental health professionals and addiction folks, but also so many people from the justice system. You know, we need to get together and talk to each other more to address some of these problems. So today I am going to talk about results from a study I'm doing. It's a very large study of prevention of suicide in the year after pretrial jail detention. And these are my wonderful collaborators. And the study is taking place here in Flint, Michigan and in Rhode Island. So, you know, this will be familiar to some of you, maybe less familiar to others of you. You know, the justice system is a complicated place. This is the Sequential Intercept model, and it's a model developed by policy research associates to show the different places that people can intersect with the justice system. So here, you know, you can start with crisis lines, a crisis care continuum, 911, local law enforcement. Locally, our police department tells me that maybe 40% of their calls are behavioral health related. And Intercept 2 here is where we can, another place we can intervene for mental health, substance use, or other interventions. And in this case, this study took place in pretrial jail detention right here. We had 800 pretrial jail detainees from 2 states. And, you know, for those of you less familiar with the system, this is more than 10 million people a year who go through pretrial jail detention. A lot of them, you go to their first court appearance, they may bail out, they may or may not be charged. or they may or may not be sentenced. If they're sentenced to a year or less, typically they'll go to jail. And if they're sentenced to a year or more, often they'll go to prison. So, I think just kind of understanding a little bit about how the system works can help you think about where to intervene in terms of mental health and substance use. And like I said, 10 million people a year are here in this initial pretrial jail detention, often for a week or less, just a few days. Some people are here, fewer people go to prison, and then, almost everyone will come back out at some point. So like I said, if you add all of those different intercepts up, not even including the crisis lines, but just start with pretrial jail detention, the justice system touches about 15 million people per year, and it's about 1 in 34 U.S. adults. So it acts as a catchment area for individuals at high health risk. The study I'm going to talk to you about started when the National Institute of Mental Health was talking to some of the colleagues and I and said, we're looking at where individuals are who are at risk for suicide, and it turns out that half of people who commit suicide aren't in any kind of mental health treatment when they do. And one of the places we think they are is the justice system. And we looked, and that was true. And if you think about this pretrial jail detention, it's often a week or less. It can be longer, but that's more than 10 million people a year, and it's almost like the emergency department of the justice system. That's where people come in. Sometimes they're manic, they might be psychotic, they might be drunk or high, they're straight off the street, they're often in acute crisis, and many of them will be back out into the community within days. And so, if you think about things you can do in an emergency department, I think you can do a lot of them in pretrial jail detention. Like I said, you got this system touching a lot of people with severe mental illness. About 20% of people with substance use disorders are justice involved. There's this saying that the 3 largest mental health treatment providers in the country are jails. And so, if you're really looking at a place in terms of population level mental health and substance use intervention, a lot of the most severely ill people and the ones who are out of treatment are having some contact with the justice system at some point. Okay, so I already talked about this a little bit. Of these 10 million jail admissions, 2/3 have lifetime mental health disorders and 3/4 have lifetime substance use disorders, and they're typically not arrested at the best moments in their life. They're often in crisis. And so, I think within the jails there's recognition that people are at risk for suicide, and they do things to screen and prevent that. But I think maybe what's less well recognized is that the rate of suicide after release is actually very high. This is a mortality rate per 100,000 people for suicide. This is the U.S. population. This is during incarceration, and this is after release. And part of the reason suicide is actually one of the top 3 causes of mortality after release, and part of the reason is people go back to the same situations they were in, but then they have access to lethal means like, drugs, firearms, vehicles. They're not under supervision like they are when they're in jail, and so there's high suicide mortality. And, again, I think about the justice-involved populations. These are the risks for suicide, different risk factors, and we're looking at population with a lot of them. There's a lot of mental health problems, bipolar, schizophrenia. There's a colleague of mine does a lot of work with trying to address bipolar in the context of justice involvement, and of people in the justice system who have bipolar disorder, more than half were arrested when they were manic, which is not a surprise if you know some of the symptoms of mania, right? It's impaired judgment, risky behavior, all of these things. So you have, high rates of health factors, high rates of these environmental factors, stressful life events, access to lethal means, and high events also of previous suicide attempts or family history of suicide attempts. So after we found this out, we went to the National Violent Death Registry and found that 10% of suicides with known causes occur following a recent criminal or legal stressor. And if brief suicide preventions are as effective in jails as they are in the emergency department, implementing them in jails could prevent 5 to 9% of U.S. suicides. And, you know, it was really interesting. Well, let me go back. It was really interesting when we talked about this, when the study came out, because people kept saying, so you're trying to prevent suicide in jail? And we said, well, yes, but mainly what we're trying to do is prevent suicide in that year after release as a way to take down suicide rates in the community, because we think a lot of the most at-risk folks for suicide are having contact with the police or the jail. So then the police or the jail become an opportunity to do suicide prevention. Okay, so, you know, what is usual care in the jails? You know, so many people go through pretrial jail detention that it is hard. It's work for most jails to do screening and assessment. They do, but it's hard. You know, a lot of the jail mental health directors will tell me, you know, we get the people that nobody else wants. You know, when they're too combative for the emergency department, they send them to us. You know, a mid-sized jail, I'm here in Genesee County, I think they have 13,000 admissions a year, which is about 50 a day. And they, you know, I want to speak for, but a lot of mid-sized jails will have one social worker. So it's just you're getting a lot of people with complicated histories and mental health and substance use through very quickly trying to figure out what to do with them. So, you know, like I said, the length of stay is often less than a week. Individuals are often psychotic, manic when they come. Jails do their best, but, you know, it's hard, and sometimes the best that they can do to keep them safe is they, you know, put them in these suits and, you know, under restrictive conditions so that they can watch them so they don't attempt suicide. So most systems serving, many systems serving those most at risk are publicly funded systems, or they're not technically treatment systems at all. So, you know, community mental health, publicly funded alcohol and drug abuse, or the police, the jails, and, you know, we have our wonderful probation officers, and I'm sure, you know, we may have discharge planners, and everyone I know does the best they can, and there just aren't always the resources needed for the level of risk and the level of mental health and substance needs for people. So, like I said, this was a SPIRIT study. It was the first randomized trial of intervention for suicide at risk reduction following release from jail. And the purpose was to reduce suicide in the community. And like I said, if it's as effective in jail detention as it is in the emergency department, implementing it could prevent 5 to 9% of all suicides. So, you know, the rationale was that jail detention is a moment to engage and intervene. Folks are out of care, they're in crisis, they're going back to high-risk environments. And we looked at, you know, it is challenging mental health, community mental health, and jails in all the counties that I know are really trying to coordinate better between them, because, you know, people from the community mental health caseload will end up in jail, and a lot of folks in jail need to go back to community mental health or need to be connected to community mental health. But again, this takes time and resources, so they work on it. In this study, we enrolled 800 high-risk individuals for suicide from jails in Rhode Island and Michigan, and they were randomized to the safety planning intervention, which I'll tell you about. It was developed by Barbara Stanley at Columbia and Greg Brown at the University of Pennsylvania, or to standard care. And what we did is we had community mental health counselors come in and do the single safety planning session while individuals were in pretrial jail detention, and then follow up with some phone calls with them in the community to help them connect to services. So that was the safety planning intervention I'll tell you more about in a minute. And the study assessed suicide behaviors and related events through 12 months post-release. So, just to give you a sense of the population, and to be fair, we recruited people who either had made a suicide attempt in the 30 days prior, typically before they came to jail, or who had a method with intent to act on it in the 30 days prior. So we were recruiting a sample that was at high risk for suicide or suicide attempts, but also it wasn't hard to find them in the jails. We found 800 people in just over 2 years, and not even screening everyone. It was there were a lot there. So in this sample, on average, let's see, I'm going to say they look like a lot of jail samples across the country, but I wanted to highlight a few things. One is that about 5% are veterans. That's about similar to the national average, where 6% are veterans. Most of them have multiple incarcerations, but not all of them. Half had made suicide attempts in the past 30 days. 85% had made a suicide attempt in their lifetime. About 80% had major depression. 40% had bipolar, so lifetime mania or hypomania. Almost half had lifetime psychotic symptoms. 70% had lifetime psychiatric hospitalizations, and more than half had been in residential treatment at some point in their lifetime. Okay. So we used the Columbia Suicide Severity Rating Scale to assess suicide attempts, and this is the gold standard assessment of suicide ideation and suicide attempts. And the definition on the Columbia is any action taken with non-zero intent to die. And that's I think if you don't come from a suicide prevention background, that's an interesting definition, right? But in it are a couple of ideas, and one is that a lot of suicide attempts are ambivalent. The person, most of the time, they have some intent to die. Yeah, and so, like I said, any action taken with non-zero intent to die is a suicide attempt. And also, the Columbia doesn't really distinguish. One of the things that bothers me is when I'll hear people say, "Oh, they just are doing it for attention," and I don't think that is very rarely the case. And you can die anyway. So the Columbia is pretty agnostic to that. So, like I said, this gold standard suicide definition, attempt definition, is any action taken with non-zero intent to die. So, in our sample, like I said, most of the suicide attempts were before arrest. A few were in detention, and a few were both. But this sort of gets to the point that where jail and the police are interacting with people who are already at very high risk. And so it's a good place to intervene. So let me tell you a little bit about this intervention. Like I said, it's called the Safety Planning Intervention. It's a structured intervention. It has good evidence in emergency department populations, and it's used extensively in the VA. And it consists of a single session in person where the counselor will go over warning signs with the person, for their past attempts or when they felt suicidal, what was going on, what did they start feeling, what did they start thinking, trying to help them get aware of what's going on internally. And then fill out with the person the structured safety plan. And part of the idea of the safety plan is to have the person themselves write it if they're willing, and then they keep it, and that way when they're in crisis, they don't have to try to remember. They have something written down. And so you go through in a stepwise fashion. The first is to identify warning signs and to really think and talk that through. The second is internal coping strategies, so things you can do to take your mind off your problems without contacting another person. And this is really interesting coming from a perspective of psychotherapy, because usually you're not trying to get people to distract themselves from their problems, usually trying to get them to address the problems. But this is the idea of this intervention is to get people through the crisis and keep them alive, until they can connect with care and do other things. So the next step is to try to get them, if they're feeling suicidal or starting to have some of these thoughts, to get them to try to distract themselves from the suicidal thoughts by, listening to music or going for a walk or reading a book or doing whatever they like to do. If that doesn't work, the next step you have them do is the third step, which is people in social settings that provide distraction. And in this case, they're not, telling anyone that they're in crisis necessarily, but they're just going out and being with people and doing things. If that doesn't work, then there's a list of people that they can ask for help to say, I'm really feeling down, or, I'm worried I'm going to hurt myself. If that doesn't work, there are professionals or agencies they can call during a crisis, and this includes the Suicide Prevention Hotline. And then and we also encourage them, if you really can, if none of this works, please go to the local emergency department. And then the last thing we work with them is making the environment safe. This is restricting lethal means, like I said, things like, pills, drugs, firearms, vehicles, knives, that sort of thing. Anything that they, whatever they think about in terms of the methods is putting some distance between them and that method. And then remembering the reasons for living. And so, like I said, it's not a complicated intervention, but in emergency departments and other settings, it's been surprisingly effective. And so we thought, well, this is something we think is actually feasible in jail. Can they do it, and does it work in this population? So some initial findings. We recruited 800 people with either an attempt or a method with intent in the past 30 days. We did 2,500 follow-up interviews. And the in-jail session was completed for 390 of the 402 participants randomized to SPI. What we would do is we would recruit someone during the day if we knew they were going to have a counselor there that night, and the counselor would do the intervention at night. And we did that because, they might be gone the next day. The person in detention may be released. You just never really know. And then the counselors, like I said, would call maybe 4 times over the 6 months after to check in, problem solve, try to connect them to treatment, both mental health and substance use treatment if they needed it. And so between the initial sessions and those 4 calls after release, participants completed a mean of 3.5 of the 5 planned sessions, which is actually pretty good, just considering how much their lives change. They may be reincarcerated, they may move, they may lose their phone, all of those things. And, in terms of the sample risk, there was a lot of risk, and I'll talk more about this. There were 16 deaths. In the sample, 1 to 2 were from suicide so far, but part of what I wanted to point out with this was that there was a 2.5% annual mortality rate for a sample that was in their 30s, right? So they're dying at much higher rates than you would expect. Some of these were overdoses, some were homicides, 1 or 2 were suicides. They're just at risk. And we had more than 1,100 NIH-defined expected suicide-related adverse events, most of which are suicide attempts, hospitalizations, some non-suicidal self-injury like cutting. We needed to track all of that. So in the control condition, to give you some idea of the level of risk, we had 29% of participants in the control condition attempt suicide in the 16 weeks after release. And actually 21% total attempted suicide within the first 4 weeks after release. And 41% made an attempt in the year after release. So, this does show that we succeeded in, I think, finding people who were at risk and choosing out of the city and out of the, larger population, people going through the jail are at very high risk. I will say it's not here in the slides because the results are very preliminary. So even though this is being recorded, don't quote me on this, but our very preliminary results suggest that the safety planning intervention prevented 37% of the suicide attempts in the year after release relative to the control condition. which is pretty good, and especially considering how many suicide attempts there were. And I would say, you know, even the standard care control condition wasn't completely inert. We gave everyone a resource guide from the city, and it was surprising and I guess a little sad how valuable those were. Sometimes they asked us for extra copies to give to their friends or other people, which of course we gave them. And, you know, we, as part of the research, we had research assistants call people at 4 weeks, 16 weeks, 34 weeks, and 52 weeks after release. And in some of our end-of-study responses for people in the control condition, even just having someone to call them and check in and ask about, you know, their suicide ideation and their attempts and their mood and their life and how they were doing was valuable to some of the people. In our end-of-study responses, they said even that helped. So I think, you know, even a little bit can do a lot in this population. And actually, before I go on to the opioids, I'll say one more thing that, you know, from the point of view of even assessment, in one of the jails told us that even having our research assistants in there, you know, assessing and enrolling people for the study seemed to have a stabilizing effect in the jail, because even just having someone there to ask in detail about, you know, their suicide, their mental health symptoms, even though we didn't intend it as an intervention whatsoever, the social workers in one of the jails thought just even that had a stabilizing influence because people felt assessed and heard, I guess. So the point being that, you know, there's a lot of risk here, and you can do a little bit, you know, from our perspective as interventionists, that has a pretty big effect. So I wanted to talk now about the substance use and the intersection there. So, you know, previous research related to substance use and suicidality, you know, we've all heard about the opioid crisis. There's a lot of opioid overdose deaths, and there may be as many as 2 million non-fatal opioid overdoses per year. And if you have a non-fatal overdose, your risk of dying by overdose is 10 times. But there's this sort of recognition that a substantive proportion of opioid overdoses might be undetected suicide attempts. And this came up because, you know, in terms of us looking at this in the study, a colleague of mine was at a conference and talking to an emergency department doctor, and she was saying, oh no, all the overdoses we see are accidental. And my colleague who was working with me on this study was thinking, yeah, I don't think that's true. So it's not most of the overdoses, but it is, I think, a significant minority of the overdoses might better represent undetected suicide attempts, and I'll tell you a little bit more about that. So we also looked at the intersection of substance use and suicidality. About 80% probably of the people in Spirit have significant substance use problems, and it was interesting because from the mental health side, we had people asking, well, you know, will this intervention work in the context of substance use? And I think, you know, the answer is yes. I mean, we have to do some more analyses, but I think, you know, we have evidence that it does seem to work in a sample that is mostly heavy substance users. So, you know, this is interesting. This was our baseline descriptive data. These are the suicide methods of their past 30-day suicide attempts. And this is interesting because the self-poisoning here is higher than you would see, I can't move my clicker here, is higher than you would see in other populations across the U.S. 51% of suicide deaths are firearm-related, and suffocation is also high, and I think overdose is number 3. So this is a little different because it's attempts, not suicide deaths. But still, you know, far and away in this population, the number one way to attempt suicide was self-poisoning, or typically drug or alcohol overdose. So that was a little bit unusual. So, you know, I think the take-home there is if you have someone who's a heavy substance user, they have lethal means sitting there. You know, you got to start thinking about that as potentially lethal means. The next was, you know, what they did for the self-poisoning attempts. You know, 41% of the self-poisoning attempts at baseline included opiates. possibly in addition to other drugs. 57% included other drugs, and 30% included alcohol. So often these things are in combination, but that gives you some sense of what people are using, at least in the self-poisoning attempts in this sample. We looked at the interplay of substance use and suicidality, and we're still finishing analyzing this data, but it is interesting to look at. So, we talked about the substance use as a suicide attempt. That we have some people that use to get high every day, but sometimes they use with non-zero intent to die. We have people that collect drugs as a preparatory behavior. So they say, I called my dealer, I got enough heroin or enough cocaine to overdose just to have it in case I decide to try. And because the person uses, substances are an ever-present lethal means when suicide ideation arises. So, there was a study of suicide attempts that found that 70% of people who made an attempt decided to do that within an hour of doing it, and 50% decided within 5 minutes of doing it. So, there are people who make plans and think about it for a long period of time, but that is actually not most people who make suicide attempts. Some people will say, oh, why should we put nets on the bridges? A really determined person will just go to another bridge, and most people don't. It's typically the combination of a very bad moment with the means being there. And so, really what we're trying to do with the safety planning intervention is put distance between the person, the bad mood, the bad day, the bad thought, and the means to do it, or give them, ways to sort of cope with the moment, because like a substance use craving, if you can hold on, typically it passes. Let's see, I was going to say something else. I got distracted by the question, so I remember what I was going to say. Maybe I'll think of it. Okay, so like I said, substance use is a suicide attempt. Substance use without caring if they live or die. We have cases where people are using substances to get high, and then in an altered state of mind, the suicide ideation increases or inhibitions lower to make an attempt. Like, it just seems like a better idea, the suicide attempt. So we had, somebody who rode a bicycle off a parking garage as an attempt. There's sometimes, like I said, they may not be happy as they're getting high, but it's the altered state of mind potentiates the attempt. Sometimes, though, people will intentionally use with the goal to reduce fear to make an attempt. This isn't most of the people, but we've had a couple people say, yeah, I drank so I wouldn't be scared to make the attempt. And then we see this a lot. This fifth one is addiction and the perceived inability to overcome it as a reason for suicide. And I remember what I was going to say. The Columbia Suicide Severity Rating Scale looks at severity of ideation in terms of 5 items. The first is, do you have a wish to die? Do you ever wish you were dead or you could go to sleep and not wake up? The second is, have you had thoughts about killing yourself? The third is, have you thought about how you might do that? So that's really getting at method. The fourth is, have you had any intent to act on the thoughts or thought even for a moment that you would? So this is this intent. And then the fifth is, have you actually made a plan? And the plan is different from the method in that a plan is something like, I'm going to wait till my girlfriend leaves. I will have bought the drugs from the dealer and she leaves for work at 5 at night so I can do it then and no one will find me. So we're finding that almost no one in our sample gets to a 5. And actually, I think our sample is more impulsive than many, but I don't know in the real world, how many people get to a 5. But in this population, they don't. They have the method. They have the thought. The lethal means is there, and they go to action really pretty quickly. So on the one hand, that's scary, and on the other hand, like I said, I think methods like we're talking about in the safety plan of putting distance between yourself and the thought, putting distance between yourself and the means could be really effective. So So treatment received after an overdose suicide attempt. This is over all the follow-up. So now we're looking at the year after release. And we started asking these questions because of this conversation, that we were having with folks in the emergency department. And so, at 4 weeks, 16 weeks, 34 weeks, and 52 weeks, we asked these questions. If they had an overdose suicide attempt or a non-accidental overdose, like I said, overdose with some non-zero intent to die. Obviously, these are not fatal because we wouldn't be having the conversation with them, but non-fatal overdose with some intent to die from it, ask what happened. So did you get any treatment, Narcan, emergency department, detox, medical treatment, why or why not? So 80% got no treatment at all. So again, like I said, there's a lot of suicide attempts out there that we're not necessarily detecting or knowing about. And when you ask why, this was the most common answer, it's just not that big of a deal, right? I didn't see it as an emergency that needed that kind of help. I didn't care. I thought if I laid down it would just go away. I didn't need the hospital. I felt fine. I didn't need it. So, this is really like it's just not that big of a deal. Which is, like I said, a little bit concerning from a mental health perspective because you can still die. So it is a big deal to us, but, like I said, some of these folks making overdose suicide attempts just don't see it as that big of a deal. So some people don't like hospitals. Some are embarrassed and they don't want to deal with the people or the attention. I try to overcome what I'm going through on my own. I wasn't thinking straight. I didn't want the attention or anyone to be notified. The patient has psychosis and feels uncomfortable around people. He didn't want to talk to people and answer questions. Some don't seek treatment because of legal involvement. If they're in jail, they can get in trouble. And sometimes it's interesting. We have folks, it's not the majority, but a minority, a handful who are getting arrested because of the suicide behavior. So if you attempt suicide by overdose, you can get arrested for having drugs on you. If you, attempt suicide for reckless driving, again, that can lead to arrest. We had someone who was court-ordered to go to residential substance use treatment. She made a suicide attempt in residential treatment. The residential treatment felt like they weren't equipped to handle it, so they kicked her out. And so then she was in violation of parole, so she went back to jail. So like I said, sometimes people are arrested as a result of that. Again, I've just made an outpatient medical appointment to get my medications adjusted, and then this person didn't seek treatment because they were on the run getting high or they were feeling kind of rebellious and they didn't care. But like I said, as a provider, to me, this sort of idea that most of them don't get any treatment and they don't think it's that big of a deal, again, it's concerning. So if they did get treatment, and sometimes they were unconscious when they went in, some people sought treatment intentionally, some people ended up in the emergency department because they were unconscious or somebody else took them there. So if they were, if you did receive treatment, did you tell the person treating you that you took the substances with some intent to die, why or why not? So this was about half, right? So even if they did get in the door, that 20% that did get in the door, only about half disclosed that it was a suicide attempt. So, the reasons why my mother made me tell the truth, this I think is really useful from a treatment point of view. They asked, so he told them. He figured, what the hell? And I think that that's important, and that's one of the takeaways for me, is that if you're dealing with someone who says that they've had an overdose, say, did any part of you want to die when that happened? And if they say yes, then you need to think about that from a suicide prevention perspective. Don't panic, but start putting some things in place, because part of what's happening here is people don't ask, so providers don't ask, so people don't disclose. Somebody wanted to be honest and reach out for help. They didn't want to die. They didn't want to keep telling lies, or they knew the hospital people, so they talked to them. And then here on the second one, the providers didn't ask, right? They didn't tell because nobody asked them. They didn't want to tell what happened. They were hallucinating. He had other things he wanted to get treated for besides the suicide ideation. He didn't like the hospital. after he came down from the high, he was feeling different, not suicidal anymore, so he decided not to tell anyone. He was embarrassed. So, what I take from this, here's what I think we can do about it. As providers, part of it is, if you're working with substance-using populations, ask about suicide ideation. The Columbia has great ways to do that. If someone has a non-fatal overdose, ask, did any part of you want to die when you did that? And if so, then start thinking about maybe safety planning or some, at least talking to the person about lethal means restriction. And, there's other things here. So we have evidence-based suicide risk screening measures. We have evidence-based brief suicide prevention interventions. It looks like, I still have to finish the analyses, but it looks like SPI, the safety planning intervention, is going to be evidence-based now for justice-involved folks. But there are evidence-based interventions. We can use them. We have methods. Well, we don't. So, methods for crosswalking booking data and community mental health records are not outside our technical capability. Sometimes they're outside the jail's resources, but it's not like society doesn't know how to do this. But like I said, they're not being used largely because of resources and capacity problem. When I've done studies, it's not a motivation problem. Every jail that I've ever worked with wants to do a lot more than they can do. They just don't have the people to do it or the resources to do it. So I think as providers, those of us who sit on the provider side can understand this and go in and try to help them get the resources that they need. So, this is as an implementation target. I wanted to give you some sense of this and what you're up against, as, we're trying to use justice systems to triage, some of these large public health problems like overdose and suicide. When the SPIRIT trial came out, the National Institute of Health was excited, National Institute of Justice was excited. They ran the study, and I read the press comments, and it was interesting because people said, well, why would we pay to reduce suicide among these folks? We should be reducing suicide among veterans. And, some of them are veterans, and, why are we doing this, for prisoners? And, just sort of not understanding that pretrial jail detention is so many people, most of them get out. And in any case, like I said, we're using this system to collect folks at risk and identify people, in society at large who are at most risk for these outcomes. Another implementation target is cost-efficient training. When I did this study for major depression, we found that the intervention was effective and it was cost-effective, but that most of the cost of the intervention delivery actually was the cost for training. And a lot of jails and prisons, they might be able to get money for one-time training maybe, or time, but to do, ongoing training over time, they just don't have the resources. So, cost-efficient trainings are also needed. Better policies, for better or worse, whether it's intended or not, the justice system is one of the U.S.'s largest public health systems. If I were in charge of the world, I would better fund the community mental health system and the community substance use treatment system, because basically when people fall out of those systems, a lot of where they end up is jail. But it's hard, because a lot of these community systems are facing funding crises and people fall through the cracks, and if they go off their meds and become manic or psychotic, they get picked up by the police. And so really shoring up the community treatment system, I think, is important, and then smoothing these care linkages between jail and the community. A lot of you parole or probation officers, are seeing these folks out there, they may go on probation, and so, all of these challenges, but to the extent to which we can help people take their medications and stay in treatment and, do the things that they should do, really that stabilizes them. So another implementation target is awareness, understanding some of the basics of how the system works, jail versus prison, how lack of resources affects people leaving prison or jail. Every facility I've been in could use more discharge planners than they have. Jails are even resources and less time. When people get arrested, say someone who's psychotic gets arrested if they are on their medication. They may not get back on them for days, a week, a couple weeks. When people get arrested, say someone who's psychotic gets arrested if they are on their medication. They may not get back on them for days, a week, a couple weeks, weeks, and so even if they weren't, you know, even if they were on medication, might get destabilized when they're arrested, and then if they're released again, they might get destabilized again. So it's actually tough to keep people with serious mental illness sort of medically and psychiatrically stable through this transition. And, you know, for those of us working in the community to address the barrier, we don't want those patients. And it turns out, you know, those patients are actually, it's 1 in 34 in the U.S. right now, but there's probably a lot of justice-involved people in your practice or in your setting, and you may just not know it. You know, sometimes people will ask because it's a marker of risk or a social determinant. But in any case, you know, if you have a clinic, don't turn away justice-involved clients. Consider peer navigators or, you know, reentry-focused treatment programs. Help policymakers find ways to create incentives rather than disincentives for treating patients that come into contact with the justice system, and reduce barriers